Uh, so one of the potential benefits of this sequester was that I almost didn't make it here. And now I'm unencumbered by having actually heard the talks. So these are my comments. Given that I actually heard the tail end of Michael's talk, and Mike and I were colleagues for a decade almost, I think, at Sloan Kettering. You don't have to look at this slide yet, but I am going to say something about it. I want to echo some of Mitch's points. Concerns about the quality of data and the follow-up and issues of confounding are important ones. I think one of the challenges we face now is this tension between sort of larger and larger data sets, possibly or maybe not, being able to overcome some of the intrinsic unmeasured differences between groups. I do worry about that, and I worry that the illusion of precise information could actually move us in the wrong direction. And actually, Michael showed a slide with near the end of your talk with the diabetes. And I don't know anything about diabetes care. I actually am proud of the fact that I was 12th percentile in endocrinology in my last board's recertification. But I'm skeptical. I think it showed a mortality difference of 10-fold differences between the best drug, the green drug, I think, and the red drug. That seems inconceivable to me that a single drug could drive that kind of mortality difference. But it certainly, if I saw it as a patient and believed the numbers in front of me, it would certainly heavily influence my decision-making process. And so there is a danger, I think, that we have to be very sensitive to about putting information in front of patients that we're not as confident about, or we don't actually understand the confidence bounds or some of the twists and turns. The issue of follow-up is a really important one. I work mostly in the cancer realm, and we have a whole series of intermediate outcomes. Death is actually fairly easy to obtain, and even cause of death in cancer is a fairly reliable measure available from public data sets. But things like progression, time to progression, are not only difficult to capture because patients move around, but they're actually heavily influenced by things like surveillance schedules and things like that, which are in themselves confounded. So we worry a lot about sort of progression-free survival, even within clinical trials as being a valid endpoint, if the sort of schedule of follow-ups is deviated from for some other external reason. But I want to point out, I want to tout my own work since I didn't hear about anyone else's. It does matter. And so I'm going to show you just two slides. This is from a recent paper. I've been focused on lung cancer screening for some time, developed some models. Actually, Michael developed some models that I tagged along on to predict the risk that people would develop lung cancer later, to predict the risk that they would die of lung cancer based on simple covariates like age and smoking and occupational exposures. The models have been published multiple times, validated externally, internally. They actually work pretty well, in large part because age and smoking are such powerful risk factors and fairly reliably reported and captured. But this is what this slide shows. CT screening was recently shown by a national randomized trial to affect approximately 20% relative reduction in lung cancer mortality. We used these models to just ask this basic question. If you took people who were eligible for the trial, people were kind of on the lower and higher end of risk, the typical person, and then some people who were being sought for screening who were even lower risk than that, what did the math look like? And I just want to walk you through it. Everyone in this room is sophisticated enough to read this table quite quickly. All that is shown in here, the intervention in the trial was 3 years of screening. The follow-up was 6 years from the first screen. So what's shown here is the effect of 3 years of screening over a cumulative 6-year period. Denominator is 1,000 individuals like this person. So this is a model person, a 62-year-old male, pack and a half, that's 30 cigs a day for 35 years. Lung cancer deaths over 6 years absent screening, 19.5 per thousand, 15.6 per thousand with screening. It's a reduction of 3.9 per thousand. One over that number is 256 needed to screen. That's somebody who would have been eligible for the trial. So would this woman, 55, female, pack-a-day smoker for 30 years, number needed to screen about 4 times that, slightly more than 4 times that, because of these relative reductions. Because her risk of dying of lung cancer in the next 6 years without screening is so much lower, only 4 per thousand. Here's somebody who also would have been eligible. This is, if you will, a pretty high-risk person. 61 per thousand people would die in 6 years of lung cancer absent screening. The 20% relative risk reduction, which, by the way, the study authors have now published an analysis of interaction and found no interaction in the relative reduction in mortality across risk factors. So this is a fairly reasonable assumption that's 20% fixed across populations independent of priors. And so that's a 12.2 per thousand, or 82 needed to screen. The National Comprehensive Cancer Network has expanded this to include people like this. That kind of person who's substantially lower risk, you have to screen 3,000. And I was able to find a hospital in California where I know things are just more liberal, but in the Sequoia Hospital, they're willing to screen a 40-year-old female with a pack-a-day smoker. In fact, their ad says they'll screen people who are just concerned about lung cancer. That totals 35,186 people need to screen to prevent one death from lung cancer. I actually had my RA call the investigator there and say, well, how many people have you screened so far in your program? And she said 80. And apparently he said, you have a long way to go. This is the LCAP study, same kind of thing. I don't know if this is up yet, but it's in the Annals of Internal Medicine somewhere. It's not under embargo, it's just a letter. But anyway, this is what it shows. The LCAP study has been publishing for a long time. These are the median years of cohort enrollment in that study. This is an observational cohort study, screening for lung cancer. It's been in the press a lot for a variety of reasons, but this is sort of interesting. They recently published in the Annals that the rate of false positive had fallen meaningfully from this period, meaning things detected in the lung that aren't cancer through CT. And look at this. We just pulled these papers, these seminal papers that reported the prevalence of lung cancer on the initial screen in 4 different studies, same study, different cohorts enrolled at different periods of time. And shown here in green and red are the median age and pack years, just reported in table 1 of the study. And the bar is the prevalence, the number of people with lung cancer amongst all people screened at initiation or entry to the study. And look, you couldn't make these data more beautiful. These numbers, as they go up and down, the prevalence of lung cancer falls. And here's the real effect. When they had a median age of approximately, they're on the right-hand graph here, of almost 70, and a median pack years of like 45, the prevalence of lung cancer in the initial screen was more than 2%, 2.8%. Now they're screening people who are well below 30 pack years at the median, right? This is the NLST cutoff here. So all these people are lower risk, and their age is south of 60. There's been an 80% decrease in lung cancer found at the first year of scan. So anyway, the only point I'm bringing up is one I think everyone on the panel has made as well. This stuff is really useful for identifying people for interventions and also counseling about the benefits and risks. We have a number of things to do about risk communication to people running programs as well as to patients considering them. Thanks very much, and again, sorry for being late.